If we decide to test a patient for COVID-19, what is the probability or chance that a positive test result represents a patient with a disease? Clinicians and patients always want to know they can trust the accuracy of a lab test result. This has never been more true than now, given the attention on COVID-19 testing as a strategy to halt the spread of this pandemic. Today, a much debated topic in dentistry is the issue of testing dental patients for COVID-19. In this video, I will not address reasons for performing a COVID-19 test in a dental setting or speak to the merits or drawbacks of performing such a test in a dental office. I have addressed both of these matters in a previously uploaded presentation to YouTube. Instead, in this video, I will attempt to explain how to interpret positive and negative test results. In short, when testing for the virus, an antigen test causing COVID-19, what is the probability that a positive test result would suggest that the patient is infected, and what is the probability that a negative test result would suggest that the patient is not infected with SARS-CoV-2? Although I will talk only about testing for the virus, the antigen, in this presentation, the same principles to interpret test results also hold true when testing for antibodies. There are three different variables or factors that affect how a test result can be interpreted. Prevalence is the amount of disease at one particular point in time, the proportion of people who have the disease, a snapshot in time. Thus, the prevalence of a disease is a measure of how many people among a population has a disease at a specific point in time and how many people do not have the disease. For example, a prevalence of a disease of 2% means that among 10,000 people, 2% or 200 people will have the disease, and 10,000 minus 200, the remaining 9,800 people, will not have the disease. The question is, if we test those who are infected, what is the ability of the test, or how well does the test perform in detecting those that are truly infected? A test's ability to detect who among infected people really are infected is called the sensitivity of the test and is measured as a percentage of how many true positive cases the test can detect among all infected cases. In other words, sensitivity is the probability that a person with a disease will have a positive test. If 200 people who have a disease are tested with a test with a sensitivity of 90%, 180 or 90% of the 200 infected people will have a positive test result, a true positive test result, while the 20 remaining people with the disease will have a negative test result, a false negative test result. Meaning, although these people have the disease, they are falsely labeled as not having the disease. Specificity is the probability that a person without the disease will have a negative test result. In other words, specificity of a test is the test's ability to detect who among non-infected people are really not infected, and it's measured as a percentage of how many true negative cases the test can detect among all non-infected people. As an example, if 9,800 people that do not have a disease are tested with a test with a specificity of 80%, 80% of the 9,800 or 7,840 people will have a negative test result, a true negative test result, while the remaining 1,960 people without a disease will have a positive test result, a false positive test result, meaning although these individuals are not infected, they will be falsely labeled as being infected. All laboratory tests are characterized by their ability to detect a person who is truly infected, sensitivity, and the ability to determine who is truly non-infected, specificity. In order to minimize false negative and false positive results, we want to use a test with a high sensitivity, which reduces the chance of getting a false negative result, and high specificity, which reduces the chance of getting a false positive result. Test manufacturers and laboratories often report analytic sensitivity and specificity of the test, which are based on the analysis of a set of known positive and negative samples. These numbers, however, represent the accuracy of a test under ideal conditions in which specimens have been collected from patients with either high viral loads or a complete absence of exposure. Sensitivity and specificity under real-world conditions, in which patients are more variable and specimen collection may not be ideal, can often be lower than the reported numbers. A positive predictive value, or PPV, is the probability that a person with a positive screening test actually has the disease. A negative predictive value, or NPV, is the probability that a person with a negative screening test doesn't have the disease. Knowing the prevalence, sensitivity, and specificity enables calculations of positive predictive values and negative predictive values. These values can answer the question posed at the beginning of this presentation. If testing a patient for COVID-19 results in a positive test result, what is the chance that this patient actually is infected? And if the test result is negative, what is the chance that this patient is not infected with SARS-CoV-2? In the next couple of slides, I will explain these terms with the help of some graphics. In these examples, I will come from a perspective of trying to determine sensitivity and specificity, positive predictive value and negative predictive value, knowing which test results are true positive, false negative, true negative, and false positive. Later, I will change viewpoint to a more pragmatic scenario in which, if given the prevalence, sensitivity, and specificity, can we then infer the positive predictive value and the negative predictive value. Let's assume there are 100 people that are being tested for the virus. A black figure depicts a person without the virus, and a red figure depicts a person with the virus. In this example, 20 people have the virus and 80 people do not have the virus. This represents a prevalence of 20%, 20 infected persons among a population of 100. A blue background represents a positive test result, while a yellow background represents a negative test result. A red figure on a blue background represents an infected person with a positive test result, a true positive test result. A red figure on a yellow background represents an infected person with a negative test result, a false negative test result. A black figure on a blue background represents a person without the virus with a positive test result, a false positive test, and a black figure on a yellow background represents a person without the virus with a negative test result, a true negative test result. In this scenario, 30 people tested positive for the virus and 70 people tested negative for the virus. Of the 20 people with the virus, 15 people tested positive, true positive test results, depicted here as the red figures with the blue background, and 5 tested negative, false negative test results, the red figures with the yellow background. As mentioned earlier, the sensitivity is the proportion, the percentage of all persons who have the virus and test positive for the virus, true positives, to all the persons with the virus, the true positives plus the false negatives. The sensitivity of the test in this example is 15 divided by 15 plus 5 equaling 0.75 or 75%. Of the 80 people without the virus, 65 people tested negative, true negative test results, the black figures on a yellow background, and 15 tested positive. These are the false positive results represented by the black figures on a blue background. The specificity is the proportion of all persons who do not have the virus and test negative for the virus, true negatives, to all persons without the virus, the true negatives plus the false positives. In this example, the specificity of the test is 65 divided by 65 plus 15 equaling 0.81 or 81%. In the example I presented to you here, we have 20 people with the virus, 15 of them test positive for the virus and 5 test negative for the virus, leaving us with a sensitivity of 75%. 80 of the 100 people do not have the virus and 65 of those test negative, true negative test results, while 15, although they don't have the virus, still test positive for the virus, false positive results, leaving us with a specificity of 81%. A positive predictive value, or PPV, is the proportion of true positive results to the number of positive results, or all true positive test results divided by all positive, true positive, and false positive results. The positive predictive value then will answer the question: if we get a positive test result, what is the probability that the person is truly positive? The positive predictive value in our case was 50%. We had 15 people that are truly positive divided by 15 true positive and 15 false positive cases. Thus, there is only 50% chance that a positive test result actually came from testing an infected person, and 50% chance that the result came from testing a non-infected person. A negative predictive value, or NPV, is the proportion of true negative results to the total number of all negative test results. The negative predictive value will answer the question, if we get a negative test result, what is the probability that the person is truly negative? In our scenario, the negative predictive value was 70 divided by 70 plus 5 equaling 0.93 or 93%. Or, put another way, there is 93% chance that the negative test result came from testing a non-infected person and a 7% chance that the negative test came from testing an infected person, a false negative test result. Let's see what happens to the positive predictive and the negative predictive values if we keep the sensitivity and specificity of the test constant but change the prevalence. In this example, the prevalence is 20%, the sensitivity is 80%, and the specificity 90%. Here we get a positive predictive value of 66.7% and a negative predictive value of 94.7%. There is a 66% chance that a positive test result came from an infected person and a 94.7% chance that a negative test result came from a non-infected person. Let's change the prevalence from 20 to 10%, but keep the sensitivity and specificity the same. Now the positive predictive value decreased from 66.7% to 47.1%, while the negative predictive value increased from 94.7% to 97.6%. Here's another example where we only change the prevalence, this time from 10% to 1%. The sensitivity and specificity remain the same. Now the positive predictive value decreased from the initially 66.7% when we had a 20% prevalence to 47.1% when we had a 10% prevalence to now 7.5% when we only have a 1% prevalence. The negative predictive value increased from 94.7% when the prevalence was 20% to 97.6% when the prevalence was 10% and now 99.8% when the prevalence was 1%. Thus, when the disease is becoming more rare, lower prevalence, the positive predictive value will decrease, but the negative predictive value will increase. In this example, I changed the sample size from 100 people to 1 million people, but I kept the sensitivity and specificity the same. Obviously, we will have more people with true positive, false negative, true negative, and false positive test results. But as the prevalence, sensitivity, and specificity stay the same, the positive predictive value and the negative predictive value remain unchanged. Thus, the positive predictive value and the negative predictive value are determined by the prevalence, the sensitivity, and the specificity, and not by the number of people I choose to sample. In this last example, we kept the prevalence the same 1%, but increased the sensitivity and specificity from 80% and 90% respectively, to both now being 99%. A test with an improved sensitivity and specificity is a more accurate test, which should be reflected in improved positive and negative predictive values. Note how the positive predictive value increased from 7.5% to 50%, and the negative predictive value increased from 99.8% to 100%. Please note that even if we use a highly accurate test, a sensitivity and a specificity of 99%, when the prevalence is low, in this scenario only 1%, our ability to distinguish a true infected person from a non-infected person may not be better than a coin flip. In summary, when the disease is uncommon, low prevalence, and increased proportion of healthy people, the number of false positive test results, which is a function of the number of healthy persons, will increase. And as the false positive results are in the denominator when we calculate positive predictive values, the positive predictive value will decrease. As for the negative predictive value, a rare disease will have more healthy people and thus more true negative test results. And as the true negative test results are in the numerator when we calculate the negative predictive value, the negative predictive value will increase when the disease becomes less prevalent. Thus, in the case of a rare disease, our chance of being correct when we try to infer that a positive test result represents a person with the disease decreases, but we can be more certain that a negative test result will represent non-infected persons. Increases in the sensitivity and specificity will provide more precise outcomes that will improve our ability to distinguish true positive results from all positive results, higher positive predictive value, and true negative from all negative results, a higher negative predictive value. I'm going to use the example of a test that has recently been authorized by the Food and Drug Administration for diagnostic purposes in the United States. It's a test that was produced by a company called Cellex. This test has a sensitivity of 93.8% and a specificity of 95.6%. According to some reports, the prevalence of COVID-19 may today be around 0.3% in the United States. There are approximately 990,000 people with active COVID-19 among a population of 330 million people. You are using a SARS-CoV-2 test with a sensitivity of 93.8% and a specificity of 95.6%. If a patient's test result comes back as positive, the question is, what is the probability the patient is truly positive? Let's assume there are 100,000 people in our sample. 0.3% or 300 people have the virus, and the remaining 99,700 do not have the virus. A test with sensitivity of 93.8% will produce 281 true positive results and 19 false negative results. A test with a specificity of 95.6% will produce 95,330 true negative results and 4,387 false positive results. As mentioned earlier, the positive predictive value is the true positive results, 281, divided by all positive results, 281 plus 4,387, which gives us a positive predictive value of 6%. Thus, the chance that this individual is truly infected is only around 6%. Or put it another way, if you believe that the tested person is actually positive for the virus, you have a 94% chance of being wrong. Practically, if you have 2,000 patients in your practice and 0.3% may have the virus, 6 patients may be infected. And if you now decide to test a patient and you get a positive result, and you now use this test to make a decision how to treat a patient, for example special infection control procedures, you will be wrong 94% of the time. The good news is that a mistaken decision in this case would result in, for example, using extensive infection control procedures for a patient that is probably COVID-19 negative. Let's assume we have the same scenario, but in this case the patient's test result comes back as negative. What is the probability that the patient is truly negative? We still have the same criteria, 0.3% of 100,000 people, 300 people with the virus, 99,700 without the virus. A test with a sensitivity of 93.8%, meaning 93.8% of the 300 people with the virus, will give us 281 true positive results and 19 false negative results, and a specificity of 95.6%, which will produce 95.6% of the 99,700 people without the virus, or 95,313 true negative results and 4,387 false positive results. If we now calculate the negative predictive value, we take all the true negative results, 95,313, and divide this number by all the number of negative results. The true negative, 95,313, plus the 19 false negative results. This will give us a negative predictive value of approximately 100%, actually 99.98%. Thus, a negative test result suggests that the probability that your patient is not infected with SARS-CoV-2 is virtually 100%. The good news here is that getting a negative test result most probably means that the patient is truly not infected. What happens if we get a more accurate test? In this example, let's keep the prevalence at 0.3%, but increase the sensitivity to 99% and the specificity to 99%. Among a population of 1 million, a disease with a 0.3% prevalence will result in 3,000 individuals having the disease and 997,000 people that are healthy. With this sensitivity, you will get 2,970 true positive test results and 30 false negative test results. And with a specificity of 99%, you will get 987,030 true negative test results and 9,970 false positive test results, which will give you a positive predictive value of 23% and a negative predictive value of 100%. Thus, the positive predictive value will increase greatly from 6% in the previous example when the sensitivity and specificity was lower, 93.8% and 95.6% respectively, to now 23%. An even more precise test will increase the positive predictive value even further. The only thing I did here was changing the sensitivity from 99% to 99.9% and the specificity from 90% to 99.9%. The diseased and healthy individuals are going to remain the same as the prevalence remain the same. but we will now have 2,997 true positive results and 3 false negative results, and 996,003 true negative results and 997 false positive results. These test results will generate a positive predictive value of 75% and a negative predictive value of 100%. Thus we can increase the positive predictive value even further with a more accurate test. What will happen if the prevalence increases from 0.3% to 3%? Among a population of 1 million, we will now have 30,000 individuals that are diseased and 970,000 people that are healthy. The positive predictive value with this higher prevalence will increase from 75% to 96.9%, but our negative predictive value will decrease only slightly and still remain extremely close to 100%. So what are we looking for? We're looking for a test with as high a sensitivity and as high a specificity as possible, which would give us a much better prediction if a positive test result truly represents an infected person and if a negative test result truly represents a non-infected person. Unfortunately, in order to have a positive predictive value above 50% for disease with a prevalence of 0.3%, we need a test with a sensitivity and specificity above 99.7%. As we have seen, lab tests depend on a number of factors that will determine the accuracy of the test results. But there are other factors that may also play a role. For example, the timing and the quality of the samples that are collected. The Center for Disease Control and Prevention, CDC, recommends use of nasopharyngeal swab for molecular testing, meaning testing for the virus. As in most patients, the nasopharynx, the space above the soft palate at the back of the nose, appears to have the highest concentration of the virus. Nasopharyngeal swab samples are technically challenging to obtain, and a suboptimal collection may reduce the test sensitivity and increase the likelihood of obtaining false negative results in patients with the virus. Testing a swab from the oropharynx or nose is also likely to reduce the sensitivity. The timing of sample collection is also important because the amount of virus presented in the nasopharynx varies over the course of the infection. Ideally, samples should be collected near the time of symptom onset to achieve the highest test sensitivity. Patients who are infected but not yet symptomatic may have false negative test results, as may those whose symptoms are waning. In summary, with 3 different variables or factors, the prevalence of the disease, the sensitivity of the test being used, and the specificity of the test being used, we can assess the probability that the positive test result represents a truly infected person and that the negative test result represents a truly negative person. I hope this presentation provides some helpful information in how to interpret positive and negative test results. So thank you for your attention, stay safe, and make smart decisions.